no problem. So you can tell something. 1 minute.
So the first speaker is Mithun Thulasidas. His comparison of superior inferior laser peripheral iridotomies in primary angle closure disease.
Respected chair and delegates, wish you all a very good morning. So I thank KSOS for giving me this opportunity. Today I'll be presenting on comparison of superior and inferior laser peripheral iridotomies in primary angle closure disease. I have no financial interest. So as we all know, laser peripheral iridotomy is the primary treatment for angle closure glaucoma caused by relative or absolute pupillary block. And conventionally, we used to perform this procedure in the superior quadrant between 10 and 2 o'clock usually. But there have been studies reported which implicated the location of the iridotomy proximate to the eyelid margin as the cause of dysphotopsia, that is mainly due to the refraction of the tear film by the lid margin. And this was more commonly seen with the superior LPIs. Inferior peripheral iridotomy have been conventionally performed in patients who are undergone retinal surgeries, mainly those who received silicone oil. However, the efficacy of inferior laser peripheral iridotomy in primary angle closure disease was not studied in the Indian population. So the purpose of the study was to compare the side effects and efficacy of superior and inferior LPI in patients who had presented with PACD. This was a prospective randomized single-masked single-center study. The inclusion criteria was based on the International Society of Geographical and Epidemiological Ophthalmology. Those who were PAC and PSCG were included. Among those who were diagnosed as PSCs, only those who had a family history of glaucoma or a contralateral eye with angle closure glaucoma or an ITC, that is iridotrabecular contact of 360 degrees, were included. These were the exclusion criteria. So the randomization was done using a binary random number generator. One eye was randomized to an LPI in the superior or inferior location, and the other eye by default was assigned the opposite location. The patients were actually masked, so it becomes a single masked study. Group 1 included eyes who had superior LPI and group 2 included eyes who had inferior LPI. And we have used the laser energy setting between 1 millijoule and 3 millijoule depending upon the thickness of the iris. The energy was determined by multiplying the energy per shot into the number of shots. Topical corticosteroid was used for a week post-procedure, and follow-up was done on day 1, 1 week, 1 month, 3 months, and 6 months. The primary outcome measures included the patency of iridotomy and the intraocular pressure, whereas secondary outcome measure included the visual side effects. The statistical methods included a paired t-test, chi-square test, and a p-value less than 0.05 was considered as significant. So initially we have screened 184 subjects, out of which 28 did not meet the criteria and 4 withdrew consent. So then we finally included 152 patients which were either randomized to superior LPA or inferior LPA group. So basically 304 eyes were analyzed with 152 eyes in each group. So this shows the slit lamp images of 2 patients who had undergone the inferior peripheral iridotomy at 5 o'clock and 7 o'clock. These are the demographic characteristics of the study population. Coming to the primary outcome measure, all the iridotomies were patent based on the gonioscopy finding and on ASOCT when we see a full thickness perforation of the iris. Intraocular pressure, both the groups showed a significant decline after the procedure. However, the intergroup difference was not statistically significant. To our surprise, the laser energy used was more in the superior LPA group compared to the inferior LPA, and this was statistically significant. The major side effects included iris bleeding, transient IOP elevation, iritis, which we defined as cells 2+ and more, and linear dysphotopsia, out of which iritis was the only side effect which was statistically showed a difference between the two groups, that is 58% in group 1 and 43% in group 2. 2 eyes reported linear dysphotopsia in both the groups. There were studies which compared superior and temporal laser peripheral iridotomy in the literature, and the initial one by Vera et al. Actually showed that the superior LPAs are more prone for linear dysphotopsia than the temporal ones, but the later study showed no significant differences between the position of the LPA and the visual disturbances. However, both these studies also pointed out that a superior LPA required more energy compared to the temporal or nasal LPA. We in our study found that the energy and number of shots required to perform LPA was more with the superior approach, but with no difference in the visual side effects. In our study, the iris bleeding was actually minimal, which was seen only in 17% of the cases compared to the reported incidence of 45%. And we also noted that during the superior LPA, when the bleeding appears, the visualization is difficult for the further shots. And the chances of an air bubble formation are also more. Superior LPA resulted in a higher incidence of post-laser iritis, which could be due to an increase in the energy used. And this was similar to the finding by Ahmadi et al. Inferior LPAs, on the other hand, required fewer shots and less power, providing easier access to the surgeon. And this could be possibly due to the patient factor, because most of the time the patient forcibly tries to close the eye, and there is a tendency for the eyeball to rotate upwards. So an inferior LPA is usually preferable in patients with dense arcus and thick iris due to easier access and better visualization. And there was no significant difference in visual dysphotopsia post-procedure. And to the best of our knowledge, this was the first study to assess the utility of inferior LPA in angle closure disease in Indian population. The strength of the study included the study design, which was a randomized single-mass study, and also the inclusion of the entire spectrum of angle closure disease. However, the study does have a few limitations. A questionnaire to evaluate patient satisfaction would have added more information, and the use of KSOCT to evaluate the parameters pre and post procedure could have been included. To conclude, both superior and inferior LPAs were equally effective, but with no significant difference in visual side effects. However, the laser energy required was left with inferior approach. Thank you for your kind attention.
You said the iritis is less than inferior.
Yes, sir.
So that is 2 plus cells you calculated.
Yes, sir.
Which day you evaluated? On the first day?
Yes, sir. Day one.
Day one.
Yes. Because
So,
almost all the iritis resolved after a week of topical
you
steroids.
said the reason is less energy, no?
Yes, sir,
That could be one.
Yes.
Another reason could be when you apply it superiorly,
The pigments actually fall down.
you will come, you will see that
Definitely,
because that also you can
Yes, sir.
that reason for that. Then why you want to do this study of
No, sir, like
inferior?
most of the time in our practice,
Yeah.
we end up doing it mostly sometimes in the inferior quadrant also, because we cannot find the proper crypt in the superior and also the access. Because sometimes when the patient actually, like I said, when the patient tries to force the eyelid, the patient tends to look upwards. And when we actually aim the laser beam, when it enters the iris crypt in an oblique way, the chances of perforation are less, because then we have to apply more shots when it is in the superior. Whereas this is much easier in the inferior. So actually we initially start just understood this difference when we did a few cases inferiorly. Then we thought, why can't we compare? Because there were studies actually, even though you say the energy performed is less, superior and temporal LPA comparison also came in the similar way, because initially people were telling like the temporal approach should be avoided. We should always do it in the superior so that the lid margin will cover the hole and avoid the side effects. But later what came out was like the side effects were more with the superior compared to the temporal because of the positioning. So in that way, the take-home message is basically you can perform it in any quadrant when you find the crypt is easily accessible, and an inferior will work as good as a superior LPA.
You said dysphotopsia.
Yes, sir.
Why was the dysphotopsia there?
Yes, sir, because that is the most common side effect which actually irritates the patient after the iridotomy, because otherwise we tell the patient like most of the time the iridotomies are safe and there are no side effects, but sometimes the patient come up with this side effect which is actually very difficult to treat also.
Why did you only patients with family history you included?
In PACS group, only those with a family history, because like the recent ZAP trial showed us that there is no point in doing a PI for every PACS patient. So in PACS categories, suspect categories, those with a family history and those who had a contralateral eye which had an attack or angle closure glaucoma were actually included.
But you said one eye inferior PI, one eye superior.
Yes,
no?
sir.
Then if it had been an attack of acute congestive glaucoma,
Yes, sir.
then how would be easy to, whether it is correct to include in your study?
No, so we have actually included even acute angle closure glaucomas in the study. Like
Okay.
the criteria included both PACS, PAC, and PACG.
Okay, so
Like all three.
so simultaneously you don't do the iridotomy. Supposing it's one attack earlier, they have done superior iridotomy or some iridotomy or something.
No, sir. Like the choosing of the eye was actually based on the randomization.
That's
So,
what I was, yeah.
that was based on
Where you
randomization.
could do both the eyes only.
Yes, sir, exactly.
Not the,
Not one eye, because
so that
all the
means if they
cases had both the eyes.
So if they had come to you for an acute attack, you would include.
Yes, sir, and also PAC with
Okay,
the
okay,
raised IOP.
okay. Now another thing is, what is the longest follow-up?
So we had 6 months follow.
That's all. That
was,
is too little.
Yes, sir. Yes, sir.
You need a longer follow-up to
Yes,
see
sir.
what is there.
Definitely, definitely.
Good study. Thank you.
Thank you, sir. Thank you.
Is there any chance of occlusion between the two?
Yes, that the actual answer for that we can make out with an ASOCD if you compare the parameters. Because even though in studies where we have compared superior and temporal, even though they say temporal is easier, it has found that the opening was more with a superior approach. So actually, we are actually planning for a different study where we actually analyze each parameter like the angle opening distance and TISA to see whether the opening is better with superior or inferior. Thank you.